I'm going to suggest that we kick things off, if that's okay. And are you able to share your slides with us, Mary? So it's a pleasure today to introduce Dr. Mary Kinloch, and her presentation is on clinical implementation of homologous recombination testing and morphological correlations for HR-deficiency and high-grade serous carcinoma. And Mary is known to many from having done her fellowship here. She is the division head for anatomic pathology in Saskatoon, and provincially is the co-chair for anatomic pathology, biomarker quality assurance and development, and the cervical screening programs for Saskatchewan. She's also the volunteer chair for the Women Leading Philanthropy campaign for the Royal University Hospital, and is the pathologist lead for CCTG's clinical trial EN10 in endometrial cancer, and as a focus on biomarker assessment of cancers, and which leads us into today's topic. Thank you so much, Mary.
Yes, thanks. So I'm joining you today from Treaty 6 territory, which is the homeland of the Métis, Dakota, Lakota, and Dene First Nation. And we here at the Saskatchewan Health Authority use our privilege of being able to work in healthcare to help narrow the gaps in health inequity between the Indigenous and non-Indigenous peoples. And thanks to Genevieve for helping organize this today. I did ask if I could come do it next week when I'm there. We did have an eventful week this week. We had a quick 40 centimeters of snow. So depending on which day I would have come, it would have been difficult to get out. But that wasn't the only exciting thing that happened this week. My sister, who lives in Vancouver, also had her baby yesterday. So I'm coming on Monday and I'll get to see this cute unnamed child, which they're still over at St. Paul's Hospital. I think that their hospital room is bigger than their apartment, so I don't think that they're really eager to leave yet. But so now that we've talked about the weather and what's been happening with my family, we'll move on to the learning objectives. And I sent these in, and after seeing them on the invitation, they seemed a little bit bland and boring. And so I thought I would combine them with a set of learning objectives that we are trying to promote by the end of 3 years with the team that you saw on that first title slide. And we're looking really for the why in our program is to try and empower patients that have ovarian cancer, to help inform them about what type of ovarian cancer they have, what different types of mutations that they can have, and then ultimately help them be partners in the decision-making process of what therapies can be offered to them. So a lot of the work that I'm going to show you today is impossible by a Genome Canada grant and an Ovarian Cancer Canada grant. And we just had the GAP grant, the Genome Canada grant, for less than a year now. So we're just starting to get results through. So we're starting to hit the stride now. So when Michelle and Genevieve reached out a couple of weeks ago, I thought this would be a good opportunity to put together what we've done so far. So for the easy part, so we're all centered in on the same thing. We all know what high-grade serous carcinoma is, that most of them begin in the fallopian tube. It's the most common epithelial ovarian cancer, with an overall 6-year survival and multiple relapses with multiple different chemotherapies during that time, and complex genetics, with up to 20% of them due to BRCA mutations. And the current state of ovarian cancer diagnosis and treatment in Canada, at least within Saskatchewan, is diverging these patients along just one fork, which is BRCA mutated or BRCA wild type. And this surrogate marker for homologous recombinant deficiency lends itself so that if you are BRCA mutant, you get the overall umbrella term of homologous recombinant deficiency, despite the fact that HRD can be caused by many different things. So you have this BRCA wild type group, which is kind of muddied in its definition of calling it HR proficient, because as you can see by the progression-free survival, you're probably contaminating this group with HR deficient, just non-BRCA HR deficient patients. So these patients aren't given something that attacks the HRD like olaparib, or that's specific like olaparib. It's given niraparib, which is also meant to be a PARP inhibitor. However, there's more significant side effects, and including life-threatening side effects for platelet deficiency. So homologous recombination repair is the point of repair of double-stranded DNA breaks, where you can utilize this other strand of DNA to create your template so that you can join back together and you can create this replication fork and ultimately have the cell survive. But if you have a BRCA mutation, you can't participate in that and undergo this non-homologous end joining, you end up accumulating these genomic instability aspects like that are loss of heterozygosity, tumoral allelic imbalance, and large structural transitions, which then accumulate the genomic scarring that we see. So when we're talking about HR deficient ovarian cancers, we're talking about the cause, which can, like I said, have multiple causes, the majority of which are BRCA1 and 2 mutations, but can be mutations in any other HRR genes, and also BRCA promoter hypermethylation. But then we have to recognize that there's an effect to those mutations, of which is the accumulation of these genomic scars. And HRD testing is based upon measuring those genomic scars. So if you were to take a look at this pictorially, if you had 100 women with ovarian cancer and you did tumor-based BRCA testing on all of them, which again is the Canadian standard, that you would see that approximately 25 of those women would be BRCA1 and 2 mutated. And they would receive a surrogate HRD status and be offered olaparib. 75 of these are non-BRCA1 and 2 mutated. They're given the surrogate HRP status and they're given niraparib. When really, if you were to augment that with HRD testing, you would find that only 25 of those would be non-BRCA HRD, whereas there would be 50% true HRP. So their HRD status is affecting their response to PARP inhibitor. So taking the fact that 50% of women are HRD, what we're doing with tumor-based BRCA testing is really only identifying 44%. We can augment that using HRR genes and get up to 60%, but really the gold standard should be looking at the BRCA, HRR genes, and genomic instability to get 100%. So there's many different ways that you can measure HRD, and there's not really a standard in Canada because the gold standard is this proprietary test through Myriad Genetics, which uses an assay and has an analysis that's proprietary. It's giving you an integer number that's a genomic instability score. So basically, if you're over 42, then that means that you're considered to have homologous recombinant deficiency. So there's lots of other ways that we can test for it through different platforms, but we haven't been able to clinically validate something to be a surrogate in the Canadian market that can take the place of Myriad Genetics. Although you can see here that some of the candidates, like the Illumina vendor, using the NextSeq platform with the MyChoice CDX assay, which is similar to the assay that they're using at Myriad Genetics, same technology, same interrogation, same output. but not sure, like the analysis, you can use the Illumina Connected Insights, or you can use Sophia Genetics Insights, which I'll talk about later. But it hasn't really been validated in our lab, clinically validated, to try and be a surrogate for myriad genetics. So that was one of our, using the why as what I showed you before, that was our what, is to optimize the HRD determination from both FFP and fresh frozen ovarian cancer tissue, and to clinically validate the HRD testing across these platforms to the gold standard. So pictorially, we utilized the U of S Gyne-Onc Biobank and partnered with SHA to, over at the Advanced Diagnostics Research Lab, run patient ovarian cancer tumors against all of these platforms and send out to Myriad to try and compare against all of these platforms. So just to reiterate that we are hoping to get a further clarification on this HR proficient group to evaluate them with next generation sequencing and OGM to try and reclassify these patients. So to talk about some of the effects of the genomic scarring, I'm just going to show a little bit about what we have for some of the results. Because the way we utilize, or historically that I have utilized next generation sequencing, is analogous to reading a book. So if you take a chapter book and you go through, and if you can think of doing something like the point mutations that you've done with BRAF V600E for melanoma or colorectal cancer, what you would be seeing pictorially in a chapter book is that a word might be misspelled. So it might have a different letter in it. So you would be able to reference a dictionary and you'd be able to see that that word was misspelled. When we're looking at genomic scarring and the output from it, it would be like having whole chapters missing, or having a chapter in the wrong spot switched with another chapter. So you're not really going to be able to identify that there's a problem unless you're actually reading the book and making sure it makes sense, because the words may look normal or be spelled correctly. So just to orient ourselves here, when we're looking for homologous recombinant deficiency, we are looking at the backbone of all of the chromosomes, and you're trying to center around this central blue line, although it's a little bit lower here. So this this kind of dashed line. So what you're looking for is all of the different TAIs, LOH, and LSTs that they're going to put up here that are corresponding with the chromosomes. And I'll just show you one of the examples here. This one had a very low myriad score on it. So I'll just give the Cole's notes here. So if you can see on chromosome 9, you can see that chromosome 9 down here, you're going to be seeing that it's coming down below that dashed line. This is just very high overview. And you can see that over on the X chromosome, you've got it polarizing towards one end, which means that there's a double representation of that X, and there's nothing on the Y. So this was a female. So, but again, this had a very low GIS score from myriad of 2. And you really only see that it has this one chromosome abnormality. There's something on 8 here as well too, right at the end here. So this one is accumulating more genomic scars, and you're being able to add up these numbers. And that's really all it is that you're adding up these genomic scores. It's just hard to identify them. So I want you to look at this pink area. This is where they're using to center along that area that is at 0. So this is important for QC, and that's going to become important for later. So I want you to look at how tight this banding is along, this colored banding is along the background. So you can see here that there's accumulation of more genomic scars, and that they are represented here as coming above or below the baseline. And this is what you're getting from Myriad. So what they will give you is an integer score, and that if it's over 42, it's considered homologous recombinant deficient. And then if it has a positive clinically significant mutation and they identify it. So this one is HRD positive and it has an HR mutation. So you can say that it's giving you the cause and the result in this. And then for this one, it's a different type of mutation, but still in the HRR pathway, so cause and result, and they correlate. For this one, the genomic instability score is above 42, it's HRD, but it doesn't have an HRR mutation in it. So there's another cause here that's allowing it to accumulate genomic scarring. It's still considered HRD, but it's not giving a clinically significant mutation. So first I'm going to show you the verification that we had between Thermo Fisher and Illumina. And this was done using the two platforms. So Illumina using the TSO 500 HRD assay, and then the Thermo Fisher OCA Plus. And I'm just going to group them into 4 different categories. So you're going to have those that have a BRCA mutation and are HRD, a BRCA wild type, but are HRD, BRCA mutation and HRP, and BRCA wild type and HRP. So I'm going to show this in another illustration, but just to alert your eyes, this is the first 48 patients that we have for both, testing for both. Tumor BRCA mutation with an HRP doesn't really make sense. If you have a cause to give genomic scoring, you should really have that corresponding genomic score be increased above 42. And there were none on the Illumina platform, but there were 5 on the OCA Plus. So just to give you an orientation just for the Illumina, the output, like I said, because it's using the same assay, it's the same output as the Myriad. It's the GIS score of greater than 42. For the Thermo Fisher, they use a GIM score. It's like genomic instability matrix. It's greater than 16, so it's a different output. But we have 5 cases here that have a BRCA mutation that's pathogenic, but then didn't give a corresponding HRD. And from that point of view right there, that was pretty concerning. And at that point, some discussion happened with Thermo Fisher about how maybe some improvement to their analysis part could be of benefit, but it wasn't looking good for Thermo Fisher to be in the front runner there. So when we're looking at the next category, those that are BRCA, that do not have a BRCA mutation but are HRD, we had a few here. And what you'll notice, what I'm going to say first of all with this is that this was fairly concordant, and there is 3 here that have really good causes in different HRR genes. I'm going to talk about the correlation here in a second. This one notably does have a cause, but didn't have an effect great enough to get it over the 16. Although it is close, like you can see that there's a number of them that are close along 14, 15, 16. This is this gray zone that not really sure what the definition of that is. Like, do they give better? Do they do better prognostically if they're closer to getting over the HRD status? And we're not sure if it's like a spectrum or is it a fulcrum? And then you have the HRP tumor-based BRCA wild type group. So this is the group where you don't have a cause and you're not really seeing any effects. And there was a couple here that tipped over. one again like that in that gray zone, but this one not concordant with the Illumina here. And again, this is just with each other. So it's not, we haven't sent it to Myriad yet. So if you don't have the gold standard of Myriad and all you have is the BRCA, which can be kind of a secondary gold standard, and you can compare it to the BRCA status, and you're looking for sort of true, like the true pauses, the sensitivity. So I think I saw that Wes Schreiber was on the line. So he's the one who said that it's positivity in disease for sensitivity and negativity in health. So when you're looking at that, you can see that the Illumina has like a complete correlation with BRCA and HRD, but Thermo Fisher is down to 60. So the comparison of the Illumina to the Myriad, at this point, I've just dropped off the Thermo Fisher because it was a little bit too muddy to do. But these are the first batch of cases that we've received back from Myriad. They go in waves, and so this data was being collected up until yesterday. So they just keep sending us results. So we're looking at that same set of cases, same mutation in HRD and no mutation in HRD. And what you're going to see, and I promise I'll come back to this, is that there's a pretty high insufficient tumor for diagnosis. Like this Myriad is like a thirsty test. And we have noticed this participating in their patient access program, is that there were virtually no, I think we've done now over 75 patients in-house, and we've never had a problem on either platform getting an answer. But for Myriad, it's in this particular cohort of patients, it was 16.7, but the experience has been that it's been like 25%. And maybe it's because it's like the last thing that we're cutting off of that block. But even when we've been using, when I can send different blocks, or they're not being recruited as part of the trial, then it's still kind of the same. And when you try and talk to Myriad, you're like, what does this mean? Was it there not enough tumor content? What does it mean? Because it'll say insufficient tumor for diagnosis, and that's all it'll say. But then there's another unable to analyze comment. And so they'll give a mutation status, but they won't be able to give an HRD number. And so what we've seen with that was that this one that was unable to analyze, they were able to confirm that there was a BRCA mutation, but weren't able to give an HRD number. So when we ask them about it, they're like, insufficient tumor is insufficient tumor, and unable to analyze is unable to analyze. So there was no conversation about what could be happening here. So when we'd have a look at this first category, and I put in the germline BRCA here for your benefit, the correlation of the Illumina to the Myriad with the BRCA mutation and HRD, what correlated in all of the patients that have come back thus far, with the exception of the insufficients. For those that did not have a BRCA mutation, but did have HRD, it correlated in 7 out of the 9 of them. And you would think that these ones here, you're expecting them to be HRD because they have a cause here. And then these ones, I'm going to show you those two in a second. These ones, you're expecting that they're going to be enriched for BRCA methylation. They don't have a reason, but we just haven't read what the reason is. So here's a look at and like I said, we're learning as we go. We're trying to, this is the first time that we have run these assays, and we're trying it on different platforms. So this was the readout of this patient here. So they have a POLB2 mutation done on the Illumina. Remember how I said that this background helps you center your reads to make correct calls? This one is all over the place. This one shouldn't have passed QC in the first place. So when they went back, they saw that there was a protocol deviation, that I think a washing step was missed. But they're going to exclude this one and run it again. It hasn't been run again, but it probably, as what we know now, shouldn't have been included. So just looking at the next group, that would be the HRP group with no tumor-based BRCA mutation. We didn't enrich this first set that we sent to Myriad with that group, but we did include a few, and those were all concordant. So looking at the PPV and the NPV compared to Myriad, using the definitions that the true positive would be HRD on both and the true negative would be HRP on both, and having a false positive meant that it would have HRD on Illumina but HRP on Myriad, and we didn't have any of those. And the false negative would be HRP on Illumina and false negative HRP on Illumina and HRD on Myriad. Here's our sensitivity and specificity thus far. So when you have a positive result, you can guarantee that it's positive with an accuracy of 94%. But if you were to take out those two that had those quality issues, but well, we're going to keep moving on with the Myriad testing and looking at it. So that was just for those top two platforms. And I think that something that's been gaining a lot of interest lately is the optical genomic mapping platform from BioNano, which is gained a lot of traction in hematologic malignancies because of its utility to do, you don't need dividing cells to do it. So you're able to get a cytogenetic picture of a DNA backbone on very high resolution, but not having to have live dividing cells. And you have this coiled, like ultra high molecular weight DNA. So the input of this needs to be fresh because formalin, as we know, breaks things up and creates small base pairs that we match back up together. You can't use that with optical genomic mapping. You need the ultra high molecular weight DNA. So we're getting like more like 2 million base pairs in size. So you have this coiled DNA, and then it's coming along this micro channel, and there's like a capillary action that like uncoils it and moves it into the these nano channels, and they have 3 that are available on each run. And what they're doing is taking a high resolution image here of this backbone, and you're getting an assembly of molecules from here, and the report out is in the Serous plot. So we're trying to use these so we have the fresh patient tumor from the ovarian biobank, and we're trying to utilize this with optical genomic mapping. So that training is going on this week. But just to show it, they're using it right now for AML, which one of the partners that you saw, John, on the grant, he's a hematopathologist by training. So he's playing around with it a little bit with acute myeloid leukemia. So I'm able to show you a couple things that they've done in their lab and how the output comes, and how we're gonna hopefully try and pair it with the knowledge that we already have from the Myriad send out. So this is what the Serous plot looks like, and it's a chromosomal representation from that backbone resolution that we saw. And you can tell that this patient has a double X chromosome because, again, you're looking for this center purple line to tell you that there is none available for the Y chromosome, and you just have X. But this is low complexity, showing insertions and deletions. And then you're having more of a complex karyotype when you're showing these intrachromosomal fusions or translocations, and then an intrafusion here. So if you were to look, like, so T519, it's pretty nice and easy. So 19 to 5, you're looking for a fusion, and then you have or a translocation, and then you have the legend on the side. And then you're showing aneuploidy gains with it. So it's giving you all this additional information, and it's not like this hasn't been the first time that somebody's thought to do this. Somebody's done it with looking for homologous recombinant deficiency in human breast cancers. So moving out from the hematologic world into the surgical pathology solid tumor world to try and get an HRD status. So hopefully at the end of this, we're going to have 2 different pathways for patients to access for their tissue, a fresh frozen pathway using ultra high molecular weight DNA with OGM analysis, and then using one with FFPE to replace the Myriad My Choice. So something else that's really interesting that's happening is that so Sophia DDM has an HRD solution with it. And so Sophia is different than the other types of HRD testing in that it does test for the BRCA1 and 2 and HR genes, but it also does this low pass whole genome score. So it's just low pass is like it's sequencing it once, and it gives you a genomic instability index score. So and so the Advanced Diagnostic Research Lab, through use of this grant, has been able to work with Sophia and get their analysis part, as well as Sophia also has access to Paola-1 trial samples that were archived and have the Myriad score with the PFS associated with it. So this was for the trial that allowed for olaparib to come on. So with the grant, we were able to acquire 40 of these archival samples. And so as the work with Myriad starts, which is happening next week after the OGM training, is that we'll be able to use the Paola-1 trial samples, which arguably is actually the gold standard, because you have the PFS with that, and not just to the Myriad test level. So to use that to run with the Illumina TSO 500 and the Sophia with their ICI, with their Sophia solution, their DDM solution, and to both run it on the same platform, the Illumina NextSeq. So that's something that's exciting that's coming up. So just how we've talked for the first half hour about what's happening within the lab, and it's very important to have that structure within the lab of getting those patient results. But I just want to touch briefly on why we're partnering, or who we're partnering with, to get those results out back to the patient. And so Laura Hopkins, who's on our team, is a gynae oncologist in Saskatchewan, and she has open and practical investigator clinically, a practical, I'm going to say it wrong, pragmatic real world investigator led clinical trial called 4PDQ, which allows for patient decision making of what type of therapy they want if they are indeed HR proficient. So to walk you through, you have patients who are diagnosed with high-grade serous carcinoma. They're getting standard of care. They go on to have their BRCA analysis. you see that if you are BRCA mutated, you're still considered in that surrogate HR deficient area and you're getting the standard treatment. If you're wild type, you undergo this enhanced genomic interrogation and treatment with counseling, and they've developed a patient decision aid with patients to decide if you are indeed HR proficient. Do you want to make an informed decision that you about taking a PARP inhibitor that is designed for patients that are HR deficient? So, and then they have their outcomes assessment with that. So the patient decision aid was just published. And I think that this is at the highest level of patient engagement with empowerment. Having the patients co-design with you clinical trials, and then patients able to make the decision about their own care. And it was very interesting to read in the discussion about how there did need to be quite the balance, and overall it tips in the patient's favor of what they thought should be in the decision aid compared to what the physicians thought. So we're the ones who need to give the oncologists their results so they can use it as part of the trial. So the progress so far is that they've been able to enroll 10 patients in, and three have received their HRP results, and 2 have chose to decline niraparib. And we're just at they started in September. And in Regina, they have 4 patients enrolled, and 2 have been you have to finish that standard of care chemotherapy first. So 2 have finished with HRP and 1 with HRD, and all 3 of them have chose niraparib. So I'm going to move on to something slightly different. So the ability to have all of the HRD scores, wanted to look at least from the position of a resident project, was the morphologic surrogates of HRD. So back in, when was this, 2012, that there was a presentation that came out of morphologic patterns of association with BRCA1 and 2 in ovarian carcinoma. So this idea of there being set criteria, solid, pseudoendometrioid, and transitional, that you can see enriched within BRCA mutated ovarian carcinomas. And that was in contrast to something like papillary or compressed micropapillary. And so our objective was to determine if the set morphologic surrogates that are seen in BRCA mutated high-grade serous carcinoma extend to the wider HRD group that are non-BRCA mutated high-grade serous. So you can imagine that because BRCA1 and 2 mutations are one cause of HRD, just want to know, is that set morphology unique to BRCA, or is it because it's part of the HRD? So patient samples were identified again from the biobank, and they did have GIS scores that were compiled using the Illumina MyChoice. They also had it compiled using Thermo Fisher, but as we've seen, the Thermo Fisher scores were a bit muddy, and they really didn't. So I have them here and you can see them, but now this was done in the summertime. So now that we're getting the results, we're starting to see a little bit about how it can be a bit contaminated. And probably this needs to just go back with the Myriad examples, the cases that have been sent to Myriad, and refine what we've seen. So the H&E slides were reviewed using this morphologic set and PMC criteria. And if you know the paper, you see that they also used tumor cell necrosis and they used a mitotic count. We didn't include those only because, and I don't know if it's probably changed since 2012, but a lot of our cases were treated cases. So they had some treatment effect in them. And we thought that would cloud a little bit about what you would be able to see. So those weren't included. So the likelihood ratios were used to determine if similar morphologic surrogates are present for non-BRCA mutated HRD and the BRCA mutated ones. So, so 63 samples were identified and met with the criteria, and you have the BRCA and the Thermo Fisher and the Illumina scores, but only collected for like some of them. So they don't quite match up all the time either. So we could do 53 for the GIM and 34 for the Illumina at that time. So now we would have the full cohort. So here's what you can see. This side is the Thermo Fisher side. So if we focus on the Illumina platform, the presence or absence of any of these features was not correlated with any of the morphologic patterns. So even the ones, so if not for, so this one is just no HRD and HRD, but there was no statistic significance between any of the patterns. And if you were to use it as a grouping, so if you were to get two features, and now when you start to break these up into the BRCA HRD groups, the numbers get really small, but there was no significant association between morphologic surrogates that were associated with BRCA and HRD. And like, so we couldn't even really make it work with the BRCA stuff. And I don't know if it's because we need to go back and see what it is based on the myriad cohort, or if it's just not really going to hold up that those morphologic surrogates are BRCA, or if it truly is that some of the treatment effect will be affecting it too much. But the prevalence of HRD did not differ significantly regardless of the histology pattern that was seen. So the initial attempts to identify this morphologic correlation between HRD and BRCA did not result in a statistical significance. But again, like we said, we're comparing again using the myriad samples. And so I just wanted to leave it there and talk a little bit about, this is John here, and this is Laura, and all the people that help us. And I guess it's probably apt to say, like, if you wanted to go fast, you go alone, and if you wanted to go far, you go together. And it's been a real pleasure to work with John and Laura in this role, because as Blake once said, you don't get to choose who you work with, but you do get to choose who you do research with. So, and you better have fun doing that part and choose wisely there. And it's truly being part of a team where we couldn't work without one another. Like, I am learning so much about the other side that John is an expert in and Laura is an expert in. But at the same time, you almost feel bad because you think, well, what am I contributing? But they literally wouldn't have the tumor samples if the lab wasn't diagnosing them. So I know that I'm contributing part of it, as is everybody on here. They all have their roles that allow things to have moved as far as we've come in just this first year. So I'm happy to talk about where we intend to go in 2 years. But I thank you very much for allowing me to share what we've done in this past year.
Thank you
Thanks
so
very
much.
much, Mary. My apologies, I was covering frozen sections, so thanks to Blake for introducing you. I'm sure his colleagues here are very interested in that statement about you can't choose who you work with, but you can choose who. So that might actually, thanks for telling us that that's what he's thinking. Yeah, I guess, are there questions for Mary? Stephen.
Hey, Mary. Got two questions. First is, how do you see HRD score being used in tumors other than high-grade serous? So for example, like prostate, we look at talazoparib being approved, and we're looking at HRD genes and like 12 HRD genes, and also pancreatic as well. Do you think they're going to have equally impact role in like olaparib or PARP inhibitor susceptibility?
So the greatest challenge that we have right now is that even if we're able to clinically validate and implement something that would be a surrogate to myriad, that's not to say that it's going to get funded for use in Saskatchewan. So that would be the biggest hurdle that I see for pancreatic and for ovarian. Prostate seems to be able to get more than the other two. So, but the biggest thing, and I think I've seen it from who's the one who does the ctDNA with the prostate, Alex?
Yeah,
That-
Alex.
with
Yeah.
Alex, is that yes, you can do it, but you're using sometimes samples that have been decalcified, and like those are the samples, and they so I wonder if the ctDNA is going to be more of a prevalent role with the prostate. And it's interesting, Stephen, if you have a few minutes afterwards, we're having some difficulty with some prostate stuff out of Regina, so we'd love to get your opinion on it afterwards.
Yeah, and I love prostate. So my second question really is about funding. So here I know that we are really, at least from life support, we're really pushing for, we're okay with like HRR gene mutation, but there's always been an issue with, are they going to fund HRD score for high-grade serous, just because the TSO 500 myriad module makes the test cost twice as much. So like, is it sustainable? And so what's your view on that? And what's the funding situation from companion diagnostic in Saskatchewan for this?
So so it's being funded right now through the grant and through the clinical trial, and Laura is helping that the clinical trial results will help influence the funding. I think we were kind of under the impression that once we were able to validate and implement, that the cancer agency would take over with cost recovery for that. But as it gets closer and closer to that date, they are starting to ask more and more questions to pull back, because they really do want to focus on that companion diagnostic to a drug. They're not seeing benefit yet in being able to stratify for progression-free survival, or even for cost savings to pull people off yet. So I think that we're probably in the same boat as everybody else is at the moment, where you have a few smart people in the province trying to convince a few people holding the money that this is going to be worthwhile, even if it's in a different silo that you're saving the money.
Thanks. Blake? Oh, Blake?
Comment, then a question. I hope you publish the morphological correlation. I see Guangming Han is on the call, and many years ago had a very large study with no correlation between BRCA mutation status and morphology, and yet the literature always says that there is this correlation because of, I guess, the publication bias towards positive results. But my question is, if you get a false negative result with an assay relative to Myriad, and they go on to niraparib instead of olaparib, how big a difference is that? My understanding is there's no head-to-head comparison of these two drugs.
So I think that at least the bias that I'm understanding between the two of them is the side effect profile. So I think that the olaparib, those patients are better to manage, but the adverse events, especially with the platelet count, it can be quite life-threatening. And so from a gyne-oncologist perspective, they would rather see patients on olaparib.
Is it possible that everybody will get olaparib sometime in the future? The nature of the clinical trials with olaparib was different than niraparib, and that seems to be sort of behind a lot of this discussion.
And so my understanding is from AstraZeneca was that because of the dosage of the bevacizumab in that trial, and was not this dosage that we give in Canada, that they would have to redo that trial to be able to offer the olaparib to the HRD patients. And so my understanding is that that's not currently in the works. So it's trying to give this real world pragmatic trial enough to be able to convince that the guidelines should change.
Thanks, Barry. Tara?
Yeah, thank you. I thought that talk was fascinating. Definitely appreciate you showing your data. I was curious about the discrepancy between the Thermo Fisher and Illumina platforms. I was also curious to know if your BRCA testing pipeline includes deletion duplication analysis and whether that might help clarify some of those potential false positive calls or.
Oh, thanks. So I understand that there are other places using Thermo Fisher for trying to do this HRD testing, and that they're not having the same issue. And so I think that what's happening from now is that Thermo Fisher is being involved in the conversation, and that their output needs to have a little bit better ability to make the calls correctly. And but I think that because Illumina took kind of a lead in that they're saying, okay, well, we're going to put our efforts into using the Illumina platform now, but the Thermo Fisher, they want to work together with it. But I do believe that it has the deletion duplication analysis, but I guess I would have to double check. I wish John was here. But I
And
didn't.
I'm also, sorry.
Sorry.
Also very excited to hear that you're going to be using OGM for looking at these tumors as well. We somewhat recently validated optical genome mapping for hematologic malignancies, but I'd really like to see it used in solid tumors. The data is not really out there, so I'm curious to see how it looks in your cohort, especially in the context of such unstable genomes, if it will perform well.
So, Tara, you must be in the cytogenetics lab or the.
Yes.
Yeah.
Cytogenomics at Vancouver General. Yeah.
Nice to meet you. Thanks
Nice to
for
meet
the
you.
question. Thanks for that input too. I'll look into that.
Thank you.
David Huntsman.
Yeah, so Ian, I had to step out for a second. I truly hope that I haven't embarrassed myself when you just answered this question. But the we've done quite a lot of low-pass WGS on FFPE looking for HRD and other signatures, and it seems to be pretty robust. We haven't done clinical validation, but it works really well on FFPE and small samples. And is this something you guys have considered doing? You obviously don't get the point mutation data in any way, but you do get very strong karyotypes across the genome with whatever density you want to dial up to.
Yeah, so the Sophia genetics DDM, that's what we're going to start doing next week. So we'll use it for all of the patients that we've already sent to Myriad. We will run that as well, but also those Paola-1 archival samples that we were able to obtain from Sophia Genetics. So they I guess that we're one of the first partners with them in Canada, and they do the low pass whole genome sequencing plus the HRR genes. And so to do the Paola-1 samples with their solution will hopefully come up with some robust results.
Thanks.
I guess one comment from Stephen was that Nira has postural hypertension and other bad heme side effects, for those that want to know. I don't see any other questions or comments. Again, Mary, thank you very much for presenting this. Very interesting. Apologies I was late, but hopefully you'll be.
Bye.
Okay. I think that's it. Bye, everyone.